Okay, all right. Welcome everybody. My name's Ian Harris. I'd like to start this session with an acknowledgement to country. I'd like to begin by acknowledging the traditional owners of the land on which we're meeting today, the Aboriginal people of the Great Duray Nation, and remind people that we're on Aboriginal land. I also acknowledge and pay my respects to Aboriginal elders past and present, and extend that respect to Aboriginal people here today. Now we're here today for the research showcase presented by South West Sydney Local Health District and the Ingham Institute for Applied Medical Research. The seminar gives the community the opportunity to support researchers in South West Sydney who've worked tirelessly to improve health and wellbeing. Now today's topic is on obesity and arthroplasty. I'm an orthopaedic surgeon and academic based here at the Ingham Institute. And this is a very topical subject at the moment. Arthroplasty, or hip and knee replacement in particular, are the two most expensive procedures performed in the country, and some $2 to $3 billion per year, which is about 2 to 3% of the health budget goes on these specific procedures. And there is a question about the effectiveness of this procedure in patients who have obesity, and also the role for reducing obesity prior to surgery. So it is a big topic, and we've got two excellent speakers today which are going to shed some light on this issue. So I'd like to introduce the first speaker. The first speaker is Natalie Pavlovic, and Natalie is currently a PhD student at UNSW. I declare that I'm one of her co-supervisors. Her thesis is focused on investigating the relationship between osteoarthritis and obesity on postoperative complications in patients under having hip and knee replacement surgery. Now, in her day job, Natalie is a senior physiotherapist who works at Fairfield Hospital, and she's going to now give her presentation. So we can hand over to Natalie, is that right? Yep.
Thank you, Professor Harris. I'll just pop my presentation on the screen.
Great, yep.
Okay, is everyone able to see that?
That's good.
Okay, thank you again for the introduction. As mentioned, today I'll be speaking about the impact of obesity on people with osteoarthritis undergoing total knee or hip arthroplasty. To start off with, I'll provide a general overview before sharing our current research findings in this area. Osteoarthritis is a chronic condition characterized by the degeneration of a joint with an inflammatory component. Joint replacement, known as arthroplasty, is often recommended as treatment for end-stage hip or knee osteoarthritis, which has been unresponsive to pain medication or physiotherapy treatment. Since 2003, the number of arthroplasties performed annually has increased 156% for total knee arthroplasty and 125% for total hip arthroplasty procedures. In 2019, 98% of primary total knee arthroplasty and 88% of primary total hip arthroplasty procedures were completed due to osteoarthritis. This number is predicted to rise as osteoarthritis continues to become more prevalent alongside an aging and increasingly overweight and obese population. With respect to obesity, the Australian Orthopaedic Association National Joint Replacement Registry collects data on the rates of obesity in people undergoing arthroplasty. According to the 2020 report, 40% of total hip arthroplasty and 58% of total knee arthroplasty recipients were obese at the time of their surgery. But why is this important? Firstly, people with obesity are at a greater risk of certain postoperative complications, including revision surgery, wound complications, blood clots, and infections. Secondly, compared to people with a normal body mass index, obesity is associated with worse, longer-term patient-reported functional outcomes, reduced mobility, and inadequate physical activity levels following arthroplasty. Thirdly, people with obesity have higher treatment costs when undergoing their arthroplasty procedure. The current arthroplasty expenditure is $1.2 billion annually. By 2030, which is only 9 years away, this is expected to be $5.3 billion annually. As such, this is a significant issue affecting both the patient and the healthcare system. Considering these facts, a model of care called the Osteoarthritis Chronic Care Program, or OACCP for short, has been established to help prepare people for arthroplasty in the New South Wales public healthcare system. The program is run by multiple sites, of which Fairfield Hospital is one. It involves a nurse and physiotherapists, but some sites also include other health professionals, such as dietitians and occupational therapists. The aim of the program is to reduce pain and improve function and quality of life. This is done by prescribing exercise, addressing weight management, and providing education about osteoarthritis according to evidence-based management. Ultimately, OACCP has been successful in addressing the impact of osteoarthritis on the healthcare system by improving a patient's readiness for surgery and ensuring patients are operated on in a timely manner. However, the impact of obesity remains an issue, with local data indicating that weight is not lost. The table below provides data from a recent enhanced recovery after surgery study conducted here at Fairfield Hospital. From a sample of 458 patients, we can see that the proportion of patients in each body mass index category is similar at baseline, which is on entry to the wait list, when compared to just prior to surgery. That is to say that approximately 60% of patients are classified as having obesity on entry to the wait list and prior to surgery at Fairfield Hospital. Overall, only 11.5% of patients lost 5% or more of their baseline weight before surgery. This is despite OACCP providing education on the importance of weight management before surgery. Now, we know that obesity is associated with greater postoperative complications. So logically, health professionals routinely recommend weight loss before elective surgery. However, little is actually known about preoperative weight loss and the effect on complications following total hip or knee arthroplasty. In fact, no definitive randomized control trial has been undertaken to test whether preoperative weight loss through diets reduces the strain of obesity on the patient and healthcare system. This leaves us with many questions. Firstly, why is it that our patients are struggling to lose weight before surgery if it's indicated? Secondly, what is the effect of preoperative weight loss in this population? And thirdly, if preoperative weight loss is worthwhile, what is the best method of weight loss for our patients? This is where our research comes in to help answer some of these questions. We first completed a systematic review to determine the effects of preoperative weight loss on outcomes following elective surgery in people with obesity. The original focus was on arthroplasty. However, a preliminary database search revealed limited evidence, so the decision was made to broaden the scope of the review to include other elective surgeries. The only exception was that we excluded bariatric surgery because this is associated with its own unique postoperative complications. An electronic search of the database identified over 15,000 articles, but only 3 randomized controlled trials met the selection criteria. Overall, 173 patients were recruited in the studies, with 82 and 87 participants randomized to the control and intervention arms respectively. Participants were aged between 21 and 85 years and had a baseline body mass index of 30 or greater. 2 studies investigated participants undergoing general surgery, which was laparoscopic cholecystectomy and hernia repair, and 1 study examined total knee arthroplasty for participants with knee osteoarthritis. Each study implemented low-calorie diets using meal replacement formulas for 2 to 8 weeks before surgery. And these are the results. Starting off with preoperative weight change, all studies reported the mean change in weight from baseline to surgery as a percentage for 159 participants. The image below shows a forest plot of the results, which helps us visualize the findings. In the top half of the image, we can see the individual results of the 3 randomized controlled trials included in the analysis. The green squares represent the mean weight lost in each individual study, and the lines on either side of the squares represent the 95% confidence intervals. The large diamond below is the summation of these results. And as we can see, this diamond sits completely to the left of the line in the middle of the forest plot. This means that the results are statistically significant and favor the intervention group. Overall, the participants lost a mean of 6.07% of their baseline weight, with the 95% confidence interval being anywhere between 10.65% to 1.48% of their baseline weight. The quality of evidence was very low, however, due to one study in particular having concerns regarding missing outcome data and selective reporting of outcome measures. With respect to postoperative complications, this was the primary outcome. Data was only available for the first 30 days following surgery in the studies. As we can see from the forest plot below, the diamond is favoring the intervention group, however, it is crossing the midline. As such, the meta-analysis did not show a statistically significant difference in postoperative complications to 30 days between the groups. The quality of evidence was low due to the very small sample sizes, making it difficult to capture postoperative complication rates. In conclusion, it's unclear whether preoperative weight loss through diet interventions reduce postoperative complications to 30 days or improve outcomes when compared to a control group due to the lack of evidence. Larger sample sizes and longer follow-up periods are required so that we can capture postoperative complication rates up until 90 days. As such, the question on what the effect of preoperative weight loss diets are remains unsolved until further trials are conducted, which leads us into our next study. Our team is currently running a pilot study at Whitlam Joint Replacement Centre to investigate the effects of preoperative weight loss further, but also to determine whether a large-scale definitive trial is feasible to be conducted at this site. 2 prospective cohorts comprised of adults with a body mass index of 30 or greater who are currently on the wait list for a primary total knee or hip arthroplasty are being followed. The study compares usual care, which is the current waitlist management strategy, to an intensive dietitian-led program, which promotes a low-inflammatory diet to reduce weight and inflammation. This diet is the Mediterranean diet, and it's inspired by the way that people used to eat in the countries that are bordering the Mediterranean Sea. So, for example, countries like Greece, Italy, and Spain. The diet focuses on a high consumption of fruit and vegetables, whole grains, cereals, legumes, nuts, with a moderate intake of fish, and the main source of fat is olive oil. This program is novel in the sense that Whitlam Joint Replacement Centre does not have a dietitian on board, and so we recruited a research dietitian to see our participants for a 9-month period. We are still collecting data on rates of postoperative complications, as some of our participants have not undergone surgery just yet. However, I can share with you the following information. To date, 20% of the usual care group lost 5% or more of their baseline weight before surgery, in comparison to 30% of the diet group. On conclusion of the diet program, 50% of participants lost 5% or more of their baseline weight. However, this was not all maintained, and that's partly due to the impact of COVID-19 affecting dietitian consultations. And 3 participants in the diet group no longer wanted surgery due to symptom improvement, and so they removed themselves from the wait list. In comparison, no participants from the usual care group have removed themselves from the wait list due to symptom improvement. Once we started completing 6-month study assessments in the pilot study, I began to invite participants from both groups to an interview regarding their experience. We thought this would be the perfect opportunity to hear why some of our patients have been struggling with managing their weight before surgery. Our aims were to explore the following: the patient's perspectives regarding barriers and enablers to weight management, the patient's experiences with the novel dietitian-led weight loss program, and the sociocultural influences on weight management. To put simply, we were interested in knowing why some participants in usual care were successful in losing weight while others were not, and whether providing a dietitian changed anything for these participants. To date, I have completed 25 interviews with participants enrolled into the pilot study. Overall, 10 participants from the usual care group and 15 participants from the diet group were interviewed. Participants were sampled according to whether they lost 5% or more of their baseline weight, which we considered as being successful with weight loss, compared to participants whose weight increased or stayed the same. We also included all participants from the pilot study who were Arabic speaking and required an interpreter. Participants who withdrew from the diet group were also invited to participate, and 4 consented for interview. I'm currently analysing the data obtained from the interviews. The data reveals that many factors can influence successful weight management, including a person's adaptability, their ability to navigate healthcare, their social context, and their weight loss beliefs. Each factor can behave as a positive influence, assisting with weight loss, or be a negative influence, becoming a barrier, depending on how it manifests in an individual. For example, a person's weight loss beliefs are shaped by their personal experience, their values, and their knowledge on healthy eating. If someone does not believe in changing their eating habits to address weight management, or if they don't think their weight is affecting them negatively, they're going to be less likely to engage in any weight loss strategies. So for example, I have a quote from one participant whose weight stayed the same. People probably would have said I was overweight, but I would say, well, I feel okay, and the knees hurt, the back hurts, but I don't feel like I'm on a downward spiral. When asked whether they thought their weight loss would help reduce surgical risk, they said, in my particular view, I would hypothetically get a date for surgery, which might be 3, 4, 5 months' time, and I would then try to lose some kilos to assist with this. In comparison, a participant who was successful in losing weight stated, well, they said the less you carry, the easier for the recuperation of the knee. That's what they said to me. So I said, okay, I put myself in the dietitian here at my family doctor. And the last time when I went there to be checked, they said that I lost 11 kilos. So as we can see, their different beliefs influence their approach to weight management. Translating this to a clinical setting, clinicians should consider these factors that can influence weight management when treating their patients to identify and target barriers sooner. The next 3 slides provide an overview of the general feedback we received. Firstly, there was a mixed response to the Mediterranean diet. Most participants enjoyed the food and associated the reduction in their pain and stiffness to the anti-inflammatory properties of the diet. Other participants who did not enjoy the diet preferred foods from their cultural background or were interested in other diets at the time, such as the keto diet. And most participants who enjoyed the diet reported that they would continue eating this way in the long term because it was more sustainable than the fad diets they've tried in the past. Participants also spoke about the support they received from health clinicians. They found speaking with the dietitian was helpful as she was able to provide step-by-step guidance on how to lose weight. Some usual care participants also commented on the minimal input that Whitlam Joint Replacement Centre is able to invest in weight management before surgery. They highlighted the need for more support in order to make a change. And some diet group participants also lacked confidence in overcoming relapses on conclusion of the diet program when the dietitian was no longer available. In reality, if the dietitian was part of the Whitlam Joint Replacement Centre service, these patients could call up at any time for advice if they were struggling, similar to how the nurse and physiotherapist provide advice when patients currently approach them. In terms of education, many participants spoke about being empowered to change their eating habits after receiving education on healthy eating. Surprisingly, most participants were unaware of their unhealthy eating habits before this program. We even had a few eating fatty takeaway foods on a daily basis. And positive feedback was received regarding the resources provided, which included a recipe book. To conclude, obesity is associated with a greater risk of postoperative complications, but research on preoperative weight loss is severely lacking. Our study has found that the Mediterranean diet is feasible for weight loss, but that weight loss is complex and influenced by many factors which should be addressed by clinicians in order to improve results. And finally, I'd like to acknowledge the study team and the Medibank Better Health Fund and Australia and New Zealand Musculoskeletal Clinical Trials Network for funding my PhD. Thank you everyone for your time today.
Now I'll just tell people what the process is for questions and answers. So I'd invite Natalie to stay online. We will have questions and answers at the end of both lectures. And the way to ask your questions is on the Q&A button on the bottom of your Zoom. If you click on that and type the questions, then at the end of both lectures, I'll be able to look through them and ask each of the presenters questions for as long as we have time. And the session is scheduled to go till 1 o'clock. So thank you very much, Natalie. Next, I'd like to introduce Sam Adie. Sam Adie is an associate professor and a clinical academic orthopaedic surgeon who's based at St George and Sutherland Hospitals and conjoint associate professor at UNSW. He's received over $1.5 million in research grants. He's widely published. He has higher degrees, both master's and doctoral degrees in clinical epidemiology. His clinical practice, he specialises in surgery of the hip and knee, including hip and knee replacement surgery, which is the topic of this. His research interests are in clinical effectiveness, particularly joint replacement and trauma. He also has a training in foot and ankle surgery. But Sam's going to talk to us today about the problems with obesity in joint replacement surgery. So I'm now going to hand over to Sam. Thanks very much.
Thanks so much for that introduction, Ian. Can everyone see my screen? So I guess my job today is to convince you that obesity and joint replacement are not a good mix. So I think Natalie's done a really good job of setting the stage for why this is such a massive problem. We do know that approximately 70,000 total knee replacements are done every year in Australia, and another 35,000 or so total hip replacements. We do know that this is getting more and more common. So if you're a male in Australia, your lifetime risk of having a total knee replacement is about 15%. And if you're female, your lifetime risk is over 20%, which is quite significant. We also know that Australia's total knee replacement rate is about twice the OECD average. So interpret that how you will. We either have better access to the surgery or we're possibly over-servicing our patients. But what we do know is that up to a quarter of patients are going to experience some sort of serious adverse event after their total joint replacement. Now, we also know that a third of Australians are obese, and that's probably the reason for why we're seeing large increases in knee osteoarthritis in particular, and the resulting increasing rates of total knee replacement. There appears to be an inconsistent association with hip osteoarthritis and obesity, but because obesity is so common in the population, we are seeing total hip replacements being done, with a large proportion of obese patients also. So what are the risks when we do joint replacements in the obese? So I would put it to you that any thoughtful reflection on the literature that's available, and you will quickly come to the conclusion that obesity increases joint replacement complications pretty much across the board. So when you're thinking about deep infection, there's a 2.5 times risk of that. There's a 30% increase in overall revision of the joint replacement. So this is where you have to go back in and revise one or more of the components of that joint replacement. There's a 50% increase in DVT. And we know that it's substantially more expensive per episode to do joint replacements in obese patients. And here's another thing, that there's a common misconception that obese people really have good outcomes afterwards, but that's probably only true in those with mild obesity. Once you get to obese class 2 or higher, we're seeing poorer functional gains when you're comparing joint replacements in those heavier patients to those with lower weight. So this was quite an elegant study from the St. Vincent's group in Melbourne that actually quantified what the economic burden is of obesity and joint replacement. So they actually calculated that the surgery itself on average actually costs about $1,200 more. The acute care costs on average cost about $1,800 more. And that actually does not factor in the downstream rehab costs. And we do know that obese patients probably utilize rehabilitation costs more so than patients with lower or normal weight. And all of this is, as Natalie mentioned, is projected to cost billions of dollars in the next decade or so also. So major public health issue. And yet we're seeing that most joint replacements are being done in the overweight and obese. So 60% of total knee replacements are obese, another 30% are overweight. So only 10% actually have normal weight. And 40% of total hip replacements are obese, just simply because we're seeing obesity become so common. Now, orthopedic surgeons love cases. We love to share cases, particularly when they're disasters, and particularly when those disasters are not your own. So this is just a case that just came up in our department just a couple of weeks ago. You don't really need to be an orthopedic surgeon to decide that there's something seriously wrong with this total knee replacement. This poor lady's leg is pointing in the wrong direction as a result. And you also don't really need a set of scales to diagnose obesity. Sometimes you can see from the x-rays here that this lady is quite overweight. So this poor lady had a primary knee replacement in 2019, was complicated by this or loosening of the joint replacement. This was then subsequently revised to a more invasive, more constrained type total knee replacement. In orthopedics, generally, the bigger the prosthesis is, the more expensive and more risky it's going to be. And then, unfortunately, this lady developed an infection as a result of this second operation. And this poor lady now has a knee looking like this. And again, you don't need to be an orthopedic surgeon to decide that that's not a very good looking knee. So this is essentially a cement spacer that's antibiotic impregnated, that we often implant for these periprosthetic infections to get the infection under control before having to now go back in again and do another knee replacement, hopefully without the complication of infection this time. So this poor lady, obviously utilizing all of these healthcare resources, obviously going through so much pain and suffering, and this is happening. So this is what I often think about then as a surgeon. If I was to offer my patients a surgery, I always have to think about what their prognostic factors are for that surgery. So these could be a whole bunch of things when you're talking about joint replacements, everything from expectations and other comorbidities. We're particularly talking about obesity today. So what we really need to ask is, what's the risk of each comorbidity? And I think I've already convinced you, hopefully, that the risk of obesity and joint replacement is quite high. But what we also need to ask is there evidence to actually modify that risk, or is there evidence to optimize the outcomes of these patients, particularly from randomized trials? So I wanted to talk to you about some specific scenarios and whether evidence actually exists for those scenarios when you're approaching a patient with obesity who is considering a joint replacement. So option one is to offer that patient a preoperative exercise program. So this is actually a space that actually does have quite a lot of high-level evidence. So this was summarized in a meta-analysis. Each of these dots on the forest plot represents a randomized trial. But what you can see is with the summary diamond there is that the effect of prehabilitation or these preoperative exercise programs is actually not very clinically meaningful. It's significant, but not very large. And there's certainly no demonstrated benefit on the complication risk of these patients post-operatively. And if I was to extrapolate that even further, so these are all comers, so that these are obese patients and non-obese patients in these trials, I would probably argue that offering a pre-op exercise program to an obese patient isn't going to get you very far. So what about this? This is a common sentiment that I see in my clinic a lot. So patients come up to you and they say, I've got a really bad joint and I can't exercise because of my painful hip or knee. So please, can you just get the surgery done for me? Because I really want to exercise. I want to lose weight. I want to get better so that I'm pain-free and I can exercise and I can potentially lose weight. So this is another option, is to actually just go ahead with the joint replacement, accept that there's going to be some increased risk, but then expect that that patient is going to hopefully lose the weight after the surgery. Well, that probably doesn't work very well either. I mean, this is data from the EPOC study that Justine Naylor led. Each of these bars here represents one of the centers including in that study, and the blue bars represent their pre-op weight and the orange bars represent their post-op weight. You can see there's not much difference across each of those centers in terms of the weight loss. And if you look at the patient's weight loss in terms of their percentage of body weight, about 64% didn't lose hardly any weight, or they were within 5% of their pre-op weight. About 19% lost greater than 5% of their body weight, but 16% actually gained more than 5% of their body weight. So on average, it probably doesn't make that much difference. So what about this option? So diet and drug-based interventions to improve weight, or more specifically in this scenario, is do these interventions actually improve outcomes or reduce complications after your joint replacement? So yes, there is lots of trial data on diets and drug intervention, but there isn't much data on weight loss prior to surgery, particularly prior to joint surgery. So there's some data that Natalie just summarized from our LIFT trial. And there's only one other small pilot RCT that was published this year that we're aware of that I'll just talk about in just a moment. So really a space that's lacking data. But the other thing is that the data suggests that large losses are actually needed to reduce your major complications after having a joint replacement. So this is data from Fairfield again. These are patients that are being classed into their different BMI categories. And the proportion of patients that then experience a major complication or readmission. So you can see here that there appears to be a tipping point around a BMI of 40. So those that have a BMI of greater than 40 have a 27% major complication or readmission rate, whereas if you get under 40, it's about 15%. So going back to that example that we had earlier of that poor lady that had a whole series of complications after her joint replacement, she had a BMI of 45 and an average height of 165 centimeters. So she weighs about 123 kilograms. Now, if you just do some simple maths, you need to be 108 kilograms just to get to a BMI of less than 40. So that's actually 15 kilograms or 12% of your body weight. That's a whopping amount. And that's just to get you over the BMI threshold of 40. And we do know that there's not a very, a strong cutoff. It's not like you get to less than 40 and that's it, you're home free. There's obviously, different exposure rates or different rates of, or it modulates your complications as your weight changes. So it's not a very simple association. This is the trial that I alluded to earlier. So this is a Swedish trial that was just published hot off the press this year. So it's a small pilot study. I think it only included about 70 odd patients. Now they actually compared an intensive weight loss program to usual care in those undergoing a knee replacement. And they actually found that 10% weight loss was actually maintained a year after the total knee replacement in those that were put on an intensive diet. So being a pilot study, obviously more data is needed to investigate the effect of all of this on your risk of complications. Now, we're about to start our own funded pilot RCT, but obviously we do need a bigger study to examine for those, the association with complications, which really is the major issue. Okay, so what about bariatric surgery then? So in other words, does doing bariatric surgery before your joint replacement actually improve your outcomes, either before having the joint or after you have the joint replacement? Does it also improve your outcomes and reduce your complications after a joint replacement? Now, we do know that bariatric surgery is by far the most effective intervention for weight loss, but it also happens to be by far the most expensive. So this study done by a group in the NHS actually looked at the cost effectiveness of different weight loss programs and really concluded that bariatric surgery is the most cost effective when you account for weight regain and the impact that obesity has on your comorbidities. But also they concluded that it happens to be the most expensive. So they said that basically if your system is able to afford the cost of bariatric surgery, then that should be what you offer these heavy patients. And in the absence of that, if you're unable to afford the bariatric surgery, then other intensive weight loss programs should be offered instead. So this is talking about all obese patients. We're not just talking about patients with arthritis and those that are awaiting a joint replacement. And if you look at the data specifically in this space, or those with arthritis or considering a joint replacement, the evidence is quite conflicting, and that's probably because it's based on retrospective or observational studies. So this one study, which was a propensity score matched analysis from New York, actually did find that there was a reduced complication rate for those that underwent bariatric surgery preoperatively, whereas a summary meta-analysis done by this group actually didn't really find, they found conflicting results. They didn't find that there was a very consistent association between bariatric surgery and better outcomes after your joint replacement. So really, this is a space that actually does need a little bit more data. Okay, so what about this option? This is the final option. This is just go ahead with the joint replacement anyway. And I would say that this is probably the status quo. We're not really seeing or doing any of the previous options in any earnest. Now, this is born out of the fact that most patients will still have very good pain and function improvements after their joint replacement surgery, but that's assuming that they don't get a really bad complication. And if I was to summarize the thoughts of surgeons when it comes to this issue, it would probably be summarized by this editorial by the editor-in-chief of one of the major orthopedics journals. And he basically is arguing that, okay, we know about the risks of obesity and joint replacement, but that's what shared decision-making is for. So you sit down with the patient, you explain those risks to them, and then you just get them to make up their own mind about whether they actually want to proceed with the joint replacement or not. And what he actually also says is that he sort of like, argues against any sort of weight loss intervention at all. And I love this quote. I've just taken this verbatim out of the editorial, is that the likelihood of a patient will lose that kind of weight and keep it off is lower than the likelihood of remaining heroin-free using methadone. So really, ignores the fact that this space is really needing more data to actually guide decision-making, and just saying it probably doesn't work anyway. So why bother offering the patient any weight loss intervention at all? So this is what surgeons think. I think surgeons believe that joint replacement surgery just works, and it probably does in most of our patients. Surgeons don't really think that weight loss preoperatively works, despite the lack of evidence, despite the fact that there's no high-level data out there. And I was actually part of a group of surgeons that was coming up with a consensus about management of patients perioperatively for their joint replacement. And I kid you not, this was actually stated that obesity is a non-modifiable risk factor for these patients. And there were several surgeons who actually voiced exactly that. Now, surgeons also don't really enjoy listening to their patients suffer. If they come to you with, an arthritic joint and you send them away and you ask them to lose weight, chances are, if you're not sending them for the right intervention, they're going to come back and they're going to still be complaining of pain and still asking you to do something for them. And the other interesting thing is that surgeons are coming up with surgical ways to actually reduce the risk of joint replacement surgery. So again, another anecdote is that I was also part of a group that was putting forward a potential trial looking at a specific type of joint replacement, one with stems or a more invasive type joint replacement that's more stable, to help reduce the risk of loosening of that joint replacement in heavier patients. So really just sort of ignoring the fact that they're heavy completely and just trying to address that with the actual joint replacement that we're doing. So in conclusion, I think obesity and joint replacements are not a great combination. I still think weight loss should always be recommended, but it needs to be an intensive program. And clearly we need more data to inform our decision-making in this space. So we need more data on these intensive diet programs, and also specifically more data on bariatric surgery in the context of arthritis and joint replacement. Thanks.
Okay. Excellent. All right. Thanks very much, both Natalie and Sam, for excellent talks. We have a few questions. There's a good participant. We've got about around 70 participants. The first question relates to medications and how medications contribute to weight gain. I might modify that question a little bit, and I'll put it to Natalie and just say, what's the role of medications, not just in weight gain, but the role of medications in weight loss?
That's a very good question. In terms of medications, we have had a few participants actually speak to me about it during my qualitative study. I remember one person in particular was speaking about the effect of the steroid medication she was on, and that had contributed to weight gain. In comparison, we had a couple of participants talk about the opposite, where their diabetes medication actually helped them lose weight because they were urinating the sugar away. In terms of how the medications are causing either weight gain or weight loss, that is beyond my expertise. So unfortunately, I won't be able to shed light on that. But in terms of the modified question from Professor Harris, we have had participants speak about being prescribed weight loss medications as a way to lose weight. And they work in a variety of different ways. So there's one particular medication that would help a person not absorb fat, so it gets excreted when they're eating food, and that's one way. And another medication would actually be affecting how a person feels hunger, for instance. These can be pricey for some participants, and a lot of research shows that when the participant stops taking this type of medication, then weight is regained.
Right. There's another question from Sarah. It's a long question, but I'll just try and encapsulate it. I have some questions along similar lines. And that's the particulars of the diet. So why a Mediterranean diet? What about partial meal replacements as an alternative? Is it one size fits all, or should we perhaps be tailoring different diets for different patients? What are your opinions around that?
Thank you, Sarah, for the question. So the first question was why we chose the Mediterranean diet. And one of the biggest factors is that the Mediterranean diet is a low inflammatory diet. So as we know, osteoarthritis has an inflammatory component, and we were really keen to see what the effect of a low inflammatory diet would have before surgery. And interestingly, we did have a couple of patients who did not lose weight, but they actually reported reduced stiffness in their joint. And they were feeling a lot better when they were getting out of bed, but they hadn't lost weight. So we're wondering whether there is a link towards the diet, and that's something that we're investigating. And it was one of the major reasons why we chose it. The other reason for going with the Mediterranean diet is that there's actually research to support the Mediterranean diet for certain such as cardiovascular risk factors. And as our participants have obesity, this is commonly associated with other comorbidities. So we thought it'd be a good way to try and see if this diet also has an effect on those comorbidities for the participants. So those are the two main reasons. And then personally, with the Mediterranean diet, it's a way of eating, and we're trying to think of the long term for these participants. So how will they go managing their weight post-operatively as well? If we think about meal replacements, that has been shown to be successful, but is it a long-term fix for these participants? So that's another factor in why we chose the Mediterranean diet. That leads on to your second question, I believe, which was the meal replacements. We haven't considered that prior to doing this study, but it's something that we're considering now, because from the qualitative interviews, we had a lot of participants in the usual care arm who were actually using meal replacements and had found great success with it. So we're wondering if there are a lot of barriers to weight loss before surgery, undergoing the Mediterranean diet. Is the meal replacement a better option for this short-term period in order to mitigate the post-operative complication rates after that? And again, it does depend on the participant. There's no one size fits all. So I think this is a case where you sit down with the patient and see what they would prefer, what's their preference, and then trial something together based on what the research is saying, plus what the patient prefers.
I might just lead on from that question before we go to Sam for the next one. I had some thoughts when you were presenting. How much of the effect, if there is any effect, of the diet is due to weight loss, which is what we're measuring, and how much of the effect of the diet is due to switching from an unhealthy diet to a healthy diet? So it's possible that we could change, not change somebody's weight, but change their nutritional status, improve it quite substantially, and that could have an effect. So have you given some thought to that, or how can we measure that?
Yeah, definitely. It's something that we're measuring via blood testing. So we're looking at the inflammatory markers to see whether or not there is a change in that level following this diet. And we're also looking to see whether participants are adhering to the diet by answering a food frequency questionnaire. So basically, we can then look at our results once we've finally collected everything and have a look at the patients whose weight didn't change, but they reported better outcomes, and then have a look at their inflammatory markers and adherence to the diet to see whether there's a link with that.
Yeah, so what sparked that question, I was very surprised when you said that a lot of patients didn't realise that they had unhealthy diets. That's quite interesting, and I think probably part of the problem. I'll go to Sam for the next question from Natalie, and it's a good question because we know that obesity and diabetes are linked. You're more likely to have diabetes if you're obese. And we know, surgeons know that diabetes is associated with more complications and obesity is associated with more complications. How can you tease those two apart, or can you, Sam?
Yeah, so the data that I presented earlier are from large data sets where they did measure the different sort of prognostic variables. So these have all been adjusted in sort of multivariable regression models. So not all obese patients are going to have diabetes and vice versa. So there is an independent association with obesity and complication risk after joint replacement. And the same goes for diabetes. I didn't talk about diabetes specifically, but certainly diabetes does have its own complication and risk profile after joint replacement.
I'll just throw in another question for you, Sam, while I've got you there. Do you think there's a role for trying to put our efforts into getting surgeons to change their culture or change their attitude? Because there is this pessimistic view, I think, amongst surgeons that it's not modifiable. It's nothing you can do about it. Just get on and do the joint replacement. Do you think maybe we should be spending some of our research effort or education effort into trying to change surgeons' attitudes? So
the problem I have with that is we actually haven't decided yet whether it is a modifiable risk factor. We don't have the data. I would argue that we need to generate that data first and then use it to guide treatment, because it may well be that, yes, we can offer them a diet and perhaps that might improve their weight on the scales, but it may not actually improve their outcome profile afterwards in terms of their risk of complications. This is the beauty, I think, of a pragmatic study like a randomized trial, is that it doesn't really need to explain the process for how we actually are improving their outcomes or reducing their complications. It is just going to show you whether it actually works or not. So once you actually we have that data, then I would argue the next step is then to convince surgeons one way or the other. Now, it may well be that we do a mega trial and we design the ideal study and we see it through to completion, and we don't really see that there's much modulation of that risk post-operatively, in which case then we can have that discussion with the patients, and perhaps it might not be a worthwhile use of our times to actually convince surgeons otherwise. Now, that sort of ignores the fact that weight loss and obesity in general is a major public health issue anyway. So I'm only now talking about arthritis and joint replacement. I'm not talking about, all of the possible beneficial effects that losing weight is going to have on your cardiovascular risk and diabetes and all of that. So I think in general, we should definitely be, but in the context of joint replacement, I think this is just an area that really needs more data to guide our approach.
Yeah, maybe the surgeons will come on board when we have better data. Okay.
Yeah.
I guess back to Natalie, there's a question there, and maybe in some of your qualitative research, have you seen difficulties or problems with patients who have a mental illness in getting them to manage their weight?
I think it's very surprising. One of the other physiotherapists who used to work at Whitlam Joint Replacement Centre did a presentation which actually spoke about how common mental illness is in people presenting with osteoarthritis. I believe there was a 50% rate with depression. So I think that a dietitian can still play a role in weight management for people living with mental illness. The treatment will still be targeting the same aspects, but perhaps you may need to do more health coaching in order to see what the barriers are for this particular participant, and maybe they need a more multidisciplinary approach to be able to achieve the same results as someone who does not have a mental illness.
The next question is from Colin. It's a good question. He's sort of saying, isn't this all too late? And I agree. I mean, ideally, we wouldn't have the problem with obesity that causes the arthritis in the first place. But, having said that, his question is it all too late when the arthritis is severe enough? So I guess his question is, can you, maybe we're just sort of, we're trying to modify the complications of surgery, but you mentioned, I think you said 7% of people on the diet group actually didn't need the surgery at all.
Yes, that's exactly right. So I think, Colin, I would have been the same as you, thinking the same before I started this research study, and then having those, that 7% actually say, no, my symptoms are better, even though if they had another X-ray, their osteoarthritis hasn't changed at all. I think that's something that's really supporting us to say, hey, why don't we actually try something beforehand to see if we can make a difference before deciding whether to go through with surgery. So regardless of what the joint looks like on the inside, there is a possibility that we may be able to make some changes with the diet, for instance.
Yeah, and I think there's some evidence that people will, particularly knee replacement, their symptoms will subside with weight loss, and it's proportional to the weight loss. Sarah's asked another question, and it's really just to be put in contact. I guess to answer Sarah's question, the people that are researching this are the people that you're looking at on the screen, but in particular, the person who's asked the next question, which is Associate Professor Justine Naylor, who works with all of us, and she's leading a lot of this research. So she would certainly be the person to get in contact with. Now, Justine has put a statement in there which I've written down here to ask as well. Is this sort of dose response effect that we're looking at, is it necessarily linear? Does it not work for people who are merely overweight or pre-obese? And also, if you lose too much weight, Like if you lost 20% of your body weight, could that be harmful? Are there, will you be malnourished and get more complications? So I think it's more a statement than anything else. These things are not necessarily pure linear relationships, and it's not as simple as we're saying. But do you have any comments on those, either?
Yeah, I mean, the example that I gave was, I used a cutoff of a BMI of 40, but that was just an example. Clearly, the relationship is not linear. It's not like you get to a certain cutoff and it's like, yes, win, and that's it. We can either get your symptoms improve or get you having the joint replacement on the next list. It doesn't work that way. There certainly is some concern that massive, rapid weight loss can also increase your risk after surgery. So, thinking about patients who undergo bariatric surgery, they do have issues with malnutrition, sarcopenia. All of those have been put forward as reasons for why in these observational studies we're seeing, that relationship is quite inconsistent. It's not just one, it's just based on weight. There's other factors going on. So yeah, there is definitely a concern for that, and I can tell you in the surgical community, in the orthopedic community, that is definitely a worry. So suggesting someone who's obese to go have bariatric surgery, there is definitely a concern that they're going to come back and they're going to have malnutrition, and they're going to be a poor surgical candidate.
Well, I think we've got like a minute or two left. Colin's asked another question about DVT. Yeah, at the moment the whole VTE prophylaxis thing is a little bit up in the air with what's the best drug, what's the best duration, do you treat people at high risk differently to the people at low risk, how do you define who is at high risk? So I might leave that question, Colin, as unanswered at the moment. And the last question is the effect of oral contraceptives on weight gain. I guess this goes back to various medications affecting weight that we have to take into account. I think on that note, I might close it because we're pretty much on time. I particularly want to thank Natalie and Sam for preparing those talks, for doing all the work. They were excellent talks, and thanks very much to the participants for their contributions. And in fact, I had some questions written down just in case, but the participants asked all the questions I was going to ask. They didn't really need to add any more. So on that note, thank you once again, and thanks everybody for participating. Goodbye.
Thanks, everyone.
Yeah.
Thanks.